Hello, my name is Dr. Janet Gillett and I'm a specialist in palliative care, and today we're going to be looking at how we might have treatment escalating planning conversations with our patients. Sadly, COVID has forced us to recognise that many patients have not had the opportunity to have an advanced care planning or a treatment escalation plan conversation, and we need to do that now. You will have received lists of those patients identified as high risk in your practice, a high risk of dying if they become infected with the COVID virus, and we need to talk to them now about their future care plans. The challenges are quite particular now in that many of these conversations will be happening over the telephone. They may be happening with patients that we do not know very well. They may or may not be known to our colleagues and our teams. Patients may well have health issues that even without COVID infection would be life-limiting. And during normal circumstances, those conversations would have happened face-to-face. However, that has now changed. In this short presentation, we're particularly concentrating on patients who we perhaps identify as palliative, in that we would not be surprised if they died within the next 12 months or so. Under normal circumstances, it would have been opportune for them to have had a conversation about resuscitation, and it was highly likely that they would have had a decision not for resuscitation. This top conversation is intended to guide clinical decisions and not result in a definitive triage decision, unless the patient is clear about the limits of treatment that they would wish to receive, or the clinical situation is such that a hospital admission would not be appropriate, that is, other than for unmanageable symptoms in the community. Conversations may be with a patient or indeed a relative if the patient is unable to undertake that conversation or lacks capacity, and we would need to adapt our language depending on who we are talking to. Before we start any conversation or telephone call, we need to be prepared. Be aware of what the medical history is. Be aware of any previous conversations that might have taken place, and indeed if there is an existing TEP which may be relevant or may be out of date. Have an idea of Rockwood frailty status, which will be available from the EMIS patient record, and also, if it's possible, to know something about the social circumstances of the person we're going to be talking with. Are they living alone? Are they providing care for someone? There are challenges to having these telephone conversations, and it's imperative that we pay attention to the cues that we receive on this, and also our empathic response throughout the conversation. We can listen for non-verbal cues: sighing, silence, irritation, anger, tone and pitch of voice, whether the person is actually listening to what we're saying by how they respond to some of our questions. There will be verbal cues as well, possibly my family's worried about me, or how am I going to manage on my own? And it's important that we pick up on these and don't ignore them. We need to be able to demonstrate empathy and kindness throughout. Phrases such as, "This is so difficult, tell me how you're feeling. I sense that you feel angry or scared. I wish things were different. It's normal to be concerned. These are indeed worrying times." People will remember kindness long after this has passed by. When we phone, it's basic. We need to say what our name is, not "I'm the doctor, I'm the nurse calling from." Give these people a name, and if we're from a team, then which team we're calling from. Introduce: "I've called because I'm concerned about you, and especially how this COVID virus infection might affect you." Perhaps you might say, "It would be helpful to talk about this now, if that's okay." It shows respect to actually seek an invitation as well from the person to continue with the conversation. It may be that now is not a good time and that you could phone back later. It might be worth asking if they have a speakerphone or if there is someone else that they'd like to be part of the conversation with. It is helpful, before we enter into more specifics of TEP discussions, to get an understanding of what the patient believes is happening with their health. There may have been a previous conversation, so we could ask, what do you remember about the conversation we had before? About your treatment, maybe about how you are. If that hasn't happened, we could start with, what do you understand about your health and the problems that you have? What are your concerns or fears about what is happening at the moment? We may need to help the patient understand the reality of their health condition before continuing. If we continue and we're on completely different pages, it's likely to result in a very difficult conversation. We need to give further information about why we're calling. Unfortunately, if you're in a group of people who may not do so well if you get infected, I am worried that if this should happen to you, there is a possibility that you might be seriously ill, or you may even die. Due to your underlying medical condition or conditions, we need to think about how you might be looked after if you get less well with your underlying problems, or if you should get infected with the virus. It's important we focus on what's important to you and think about what may or may not make a difference. I've looked at 3 scenarios that we might be we're going to consider now. First is that the patient actually does get infected with the COVID virus, and that actually clinically and medically they're unlikely to survive because of pre-existing conditions or frailty. Another scenario would be that actually they have a non-COVID problem, maybe an exacerbation of a pre-existing problem or indeed a new problem. But either way, they're unlikely to survive because of their frailty or pre-existing conditions. Another possible scenario is that they actually do get the COVID virus infection, or they have a non-COVID problem, and they may indeed survive with treatment. So these may be patients that have some risk, but also includes that group of patients who may be fit and well and more than 70. As I've said earlier, we are particularly looking at those of the risk category and not the well more than 70s. But there may be some information here that will be transferable into that group if you were to have a conversation with them. 2 questions that we need to be considering. The first would be, if you were to become infected with the virus and you get more sick, what are your thoughts about how you would like to be looked after and what would be important to you? And the second aspect of the conversation would be, if you should become less well for a different reason, what are your thoughts about how you would like to be looked after and what would be important to you? And in my experience, when we're talking about future planning, the responses may vary from, I want absolutely everything done for me, including hospital, to just keep me comfortable and let me go in peace at home, if that's possible. If we look now at that person who has the COVID infection and had been medically identified as unlikely to survive because of underlying conditions, but they're saying, I want absolutely everything doing, including hospital. Rather than saying, well, that's not going to be possible, you wouldn't survive, it would be helpful to actually try and explore where they're coming from and what's informing this statement. So we might say something like, I'm hearing that the thought of dying is too difficult to think about. Am I right? It would be helpful to try and explore their death fears or what they are most frightened about. It may be that there's something else, that they're the main carer for somebody else and they can't possibly think about dying. Here are some phrases that we might be able to use. We wish that things were different, and I'm sorry, but we are seeing that treatments are not successful for people with existing medical conditions like yours, and that intensive treatment does not work. I'm suggesting that you would go to hospital if you were unable to manage your symptoms here. Otherwise, you would stay here, and we would make sure you have drugs available should you need them to help you with troublesome symptoms. We'd also need to consider if they would need some social support as well. The resuscitation conversation is always difficult, and many people don't fully understand what resuscitation means. And I usually say something like, if your heart should suddenly stop, this would be because something very serious had happened, and we would not try to restart it again. The results of attempting resuscitation or to restart it for someone with your problems are extremely poor. When you complete the TEP, it would look something like this, with not for hospital transfer, not for life-prolonging treatment, and with no active treatments other than the possibility of using oral antibiotics. The patient with COVID infection unlikely to survive saying, I'd like to stay where I am if that's possible. It's fairly straightforward. That needs acknowledging. I'm hearing that you'd rather not go to hospital if you became unwell. Is that right? This would mean that you'd stay where you are now, and that we would provide drugs to help you be comfortable and try and support those you care about. If your heart should suddenly stop, we'd not be trying to restart it. And there again, the treatment escalation plan would look as before. A patient getting a non-COVID medical problem but still assessed as being unlikely to survive from that problem, wanting everything done including hospital. Once again, we're hearing from this person that actually it's very difficult for you to think about that you may not survive your illness. I'm sorry this is so hard to talk about. We wish things were different, but we know that more treatment for your condition isn't going to make you any better, and that going to hospital for intensive treatment, as we've already discussed, does not make any difference. I'm suggesting that you would only go to hospital if you're unable to manage your symptoms here. And again, the bit about if your heart should suddenly stop. And here's the TAP, which was as before. The person who has a non-COVID medical problem and is unlikely to survive, wanting to stay at home, again, as we've already discussed, then you would stay at home where you are now. We do what we could to support you at home so that you're comfortable and not be trying to restart your heart if it should suddenly stop. And here we can see the treatment escalation plan. Now, the group of patients who actually, either with COVID or non-COVID medical problem but may survive, we need to have a slightly different conversation. As I said before, this TEP conversation is not about necessarily keeping people out of hospital. It's about having people in the right place where they can get the best treatment for whatever's happening to them. And as we've already seen, for some people with uncontrollable symptoms, despite the fact they may not survive, hospital may be the right place for them. So these patients with COVID or non-COVID infections, who may, infections or exacerbations of underlying problems or new problems, but may survive, given that with treatment you may improve, if it is possible in these present circumstances, we would try to get you to hospital. But there are no guarantees that you will get better, and you may get the infection by being in hospital. I hope you understand that. We also know that at present there are visiting restrictions in the hospital. That means that no visitors are allowed, and this may influence the decisions we make today. We might like to ask them how that information would influence their thinking about going into hospital should they become less well. We need to clarify as well, bearing in mind that we're looking at this group of patients that's high risk, many of them would be in their last year of life anyway. There are some things that can be done to improve how you are, but this doesn't include restarting your heart if that should suddenly stop. And we see that the TEP form would look like this with DNR, but consider hospital transfer, maybe for life-prolonging treatment. And the yes for oral antibiotics, IV antibiotics, and IV fluids. And the non-invasive ventilation here is unclear. That is a critical care or a hospital decision if the patient goes to hospital that would need to be taken there. And it's not for us to make that decision. Patient who wants to stay where they are if possible, not for hospital transfer. The TEP is fairly straightforward there. Additional things we need to be thinking about before we finish completing this TEP form is who in your family have you talked with about your wish, your thoughts about the future, and how would you wish to be cared for. And there's a place on the form to put this in. If you should be unable to speak for yourself, who would you like us to talk to? Please complete this section as well. And also if they've got a lasting power of attorney for health and welfare, or an advance decision to refuse treatment. And note, if they have got one, who the attorney is and put in a telephone number. Something that often gets missed when we're talking about end-of-life care in difficult situations and treatment escalations and plans for the future. The spiritual needs. We're all spiritual beings, one way or another, and we need to acknowledge that our patients may well be frightened, that reality of dying has suddenly become a possibility. They may be questioning everybody, God, health services, themselves for past deeds. They may be trying to make sense of what it means to be human and asking, who am I, what's life been all about? We need to allow space for this in our conversation and acknowledge their psychological and spiritual pain. Some questions that you might find helpful here are, when things have been difficult in the past, where have you drawn strength? Or what's been important for you in your life? Or what has given you hope? A few minutes spent on this is time well invested. So in summary, in order for you to be looked after, we'd say to the patient, as we've agreed, we need to write this on a piece of paper called a treatment escalation plan and make sure that those looking after you can see what we've discussed. You need to have this paper in your home, and I will get it to you. Put it somewhere where someone can find it, maybe on your fridge. Your GP will also have a copy on your medical record. That is if you're not the GP speaking. We need to make sure that we scanned a copy to tep.somerset@nhs.net, and then this will be forwarded to the patient's GP record. At present, during this pandemic, EMIS is the source for all healthcare workers to view TEP information. So it's very important that it is available on EMIS for us all to view. And finally, can you allow time for questions? Is there something else you'd like to talk about? And it may be, I don't know what's going to happen to my dog or my cat. I don't know who's going to look after this, that or the other. And we need also to be thinking out what sort of social support they've got and whether we need to signpost them to get more help from somewhere else. So thank you for listening. I hope this has been helpful. There will be some further listings of help for care for the dying patient and also breathlessness management will be shortly available for you. Thank you.